Good afternoon, everyone. My name is Patricia Noga, and I'm the Vice President of Clinical Affairs at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, Achieving Age-Friendly Care Regulation with Meaningful Results, the Niche Practice Model. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2026 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of the many events we offer throughout the year to connect our members with leading experts to help address timely issues like the one today. I'm pleased to introduce these esteemed nurse leaders who are our speakers today. Arlene Stoller currently serves as the Geriatric Clinical Nurse Specialist and Niche Program Leader at Leahy Hospital and Medical Center. She has been a registered nurse for over 32 years and is passionate not only about caring for patients and families, but also, just as importantly, about advancing the profession of nursing. She has been a member of the Accredited Approver Unit since 2018 and has since gone on to become a co-chair of the American Nurses Association of Massachusetts. In addition, Arlene serves on MHA's Engaging with Aging Advisory Group. Karen Mack is the Executive Director of the Nurses Improving Care for Healthsystem Elders Niche program at NYU Rory Myers College of Nursing, where she leads national efforts to advance age-friendly nursing care across more than 350 member organizations. With more than 4 decades of clinical and leadership experience, Dr. Mack has dedicated her career to improving outcomes for older adults and driving system-wide excellence in nursing practice. Thank you so much for being here today, both Karen and Arlene, as we are looking forward to this discussion. I will hand it over to Karen to get us started.
Thank you, Patricia. We were so excited to be with your members today and share a little bit about our success with niche and also how we closely align with other geriatric nursing and other geriatric quality organizations across the spectrum. It's my privilege to be with Arlene Stoller, my colleague for over a decade. I was a frontline niche leader, and Arlene was a wonderful colleague and mentor to me as I began the work. So it's a privilege to be presenting this a webinar with her today. Next slide. So what we'd like to accomplish in terms of outcomes for this discussion is to understand how the Nurses Improving Care for Health System Elders, niche, practice model develops a knowledgeable and engaged nursing workforce. To describe some success stories and tactics niche organizations use to meet the CMS Age-Friendly Measure with patient-focused results. And we'll also describe the impact of niche nursing leadership on operationalizing diagnosis and care for patients with Alzheimer's disease and related dementias, ADRD, in hospital settings, with which Arlene has led within your state. And so she's a leader in this area. So next slide. And so aging population, these slides have been in existence for years, right? The tsunami is coming of the end of the boomer generation. I am on the tail end and I become an older adult in a week. So these numbers have been in the purview for years, but let's give you an update, right? By 2050, older adults age 65 and up will increase by 40% to 82 million compared to 58 million last year. Older adults comprise less than 13% of the population, but are more than 40% of hospitalizations, and most have at least one multiple chronic condition, and 60% have at least two. These are patients in your organizations who are the people you serve every day. 23% of the state of Massachusetts is now 60 or older, with 17% being 65 and older, and nearly half of all hospitals incur costs and care for older adults. And the fall death rate has increased by 41% from 55.3 per 100,000 in 2012 to 78% per 100,000 in 2021. And this is a major focus. I was recently last week or 2 weeks ago working with a major health system here in Manhattan with a fall summit, really looking to optimize and prevent serious injuries and death with falls. And we really focused on mobility, and we'll talk more about that, right? Mobility is not the enemy of falls. Mobility is the friend of falls. Next slide. So what is age-friendly care? It is staying well in the community and residential settings. That's our optimal goal. And then, as we age and throughout our, lifespan, but particularly more as we age, there are episodic illnesses that result in emergency and acute care, or there may be procedures that we need that result in acute care or peri-op settings. But we want to make sure that when those things occur, that people get back to their baseline. Because it has a huge impact on their quality of life moving forward. And lastly, right care to optimize the quality of life for chronically ill and end-of-life stages. It is person-centered. It prioritizes the patient's goals of care. It asks what are their goals of care. It is highly reliable. It avoids preventable errors, particularly medication errors. And there's a lot of work to continue to do in that space. It optimizes processes that preserve wellness, such as mobility and cognitive health, and it considers the likelihood of benefits to risks when choosing interventions. Next slide. So what is the solution? Niche is part of the solution. There are other excellent geriatric quality organizations, but we'll focus on niche today. Healthcare leaders need solutions to achieve regulatory requirements and outcomes. And older adults need personalized care that values them and does not stigmatize them. And the solution is a knowledgeable and engaged nursing workforce. It's certainly a knowledgeable, engaged all workforce, but our work with niche focuses first on the nursing workforce and begins to then have them influence their colleagues across the organization. So it's a solution is having knowledgeable, engaged nursing workforce to really see the patient, enjoy taking care of the patient, have an opportunity to make a difference with their nursing expertise in the care of the patients. Next slide. And so niche, and I always pronounce niche with an invisible T for the reason on the left. Dr. Terry Fulmer is our founding dean, NYU Myers, where niche resides. Inaugurated niche during Dr. Fulmer's deanship as our founding dean. And it was the work that she did at the Boston Beth Israel Deaconess Organization in the 1980s in developing a geriatric resource nurse model and also developing clinical protocols. I believe it was Dr. Joyce Clifford was essential in that work at the Boston Beth Israel Hospital. And so that work during her deanship was inaugurated formally as a niche program in 1992. And on the right is Dean Angela Amar. Dean Amar is our current dean and is a strong supporter of niche. She is the president-elect of the American Academy of Nursing. And in the center, you see our beautiful building we share with the College of Dentistry on First Avenue in Manhattan. We had a wonderful niche conference there last week with over 120 individuals, and we were very pleased to present Dr. Fulmer with the Niche Nexus Award for Geriatric Innovation. Certainly with niche, there's such a strong connection, and the work endures and continues to be very effective. But we are very indebted to Dr. Fulmer and also Dr. Donna Fick, who was their very first geriatric resource nurse, and I'll tell you a little bit about that. Next slide. And so this is our niche practice model. During my predecessor's executive directorship, it was recognized as an edge runner, nurse-led model of care by the American Academy of Nursing. Edge runner models of care are shown to be effective and nurse design. And we're very proud of that recognition. And so there's four components. The first two really began during Dr. Fulmer's work in Boston and continued throughout her career until it was inaugurated here at Myers, NYU Myers in the early 90s. But the first piece is really that geriatric resource nurse model, where there is a nurse champion. It may be a registered nurse, but it may also be a LPN or LVN. And it begins with strong education. We have an online learning center called the Niche Knowledge Center, and there's a geriatric resource nurse learning path. It is 17 modules, about 14 contact hours, and each module conveys contact hours, and so they accomplish that over a period of time. And then they have a much stronger foundation, and our nurse leaders report that as they begin to do this learning, there's a light that comes on in their minds to see geriatrics as not a population to be avoided or stigmatized, but a population where they can make a significant impact and enjoy their practice. The GRN role goes on, though, from being clinical experts themselves to being leaders with their peers and other disciplines on the unit. They engage in improvement, practice change and improvement projects through evaluating implementation of our geriatric protocols that I'll discuss in a second. And they work within their shared governance models or clinical models within their organization to share that work, to spread and engage others. There is an associated role called the Geriatric Patient Care Associate for geriatric or any CNAs or techs in the organization. There is also a learning path for them, and that has 14 modules, and it takes about 10 hours to complete. And they also have a role description about being the eyes and ears of the nurses, to being advocates for their patients. And it's amazing to see the light go on and the pride of our CNAs and nursing techs in that role. Personally, having served as a frontline leader during the pandemic, I recall a rounds one morning when we were doing multidisciplinary rounds outside the unit and or outside the room, and the CNA walked out and said, "I'm really concerned my patient's coughing while I feed her. Can you come in and look at the patient?" And in fact, the CNA was the eyes and ears of the whole team that day and identified that the patient was having aspiration. And they knew that because they had completed education to understand feeding issues with older adults. So that's our first component, the GRN model. It continues to be a highly successful model. We had nurses presenting who had just finished their nurse residency, who focused on improvement work during their nurse residency, presented our conference here at NYU last week, our niche conference, and we're very proud of their work and very engaged. The second component are clinical evidence-based practice protocols. This began in Boston in the 80s and now is a textbook in its 7th edition. Dr. Fulmer and 2 other former niche leaders continue to edit the textbook. There are over 30 evidence-based protocols. It focuses on preventable geriatric syndromes, things that can happen in the hospital that don't need to, right? That people become deconditioned because we're not mobilizing them. Where we give them medications that maybe aren't at the right dose or or even really needed, but because historically that was the practice. And so it allows them to understand what are the evidence-based practices for over 30 conditions. It includes assessment, management, specialty care, and ED, critical care, oncology, also chapter on palliative care, transitions of care. So it's a rich resource that then they can go to their unit, look at their intervention, the recommended interventions and practices, do a gap analysis, and begin that change management work. The third component is care transitions. As they do that care change management approach, they often find, for example, there's opportunities with other disciplines and other departments. Maybe the niche program started on a medical surgical unit or an ED, and at that point they realize, well, wait a minute, let's get the ED or critical care involved and start to look at how we're managing these patients together. At that stage, pharmacists, social workers, case managers, physicians, quality specialists are all essential. and they collaborate together within a niche steering committee to work on care improvement and analyze their data and see what the opportunities are as an organization. And lastly, the fourth component is looking at the physical plant for older adults. There is a protocol in our textbook about the optimal prepared environment. And we also focus in on, for example, are the toilet seat heights right? Or there's good use of contrast? Or the walkways uncluttered? Or is there a good process around engaging the safety specialists in the organization to address the standards, not just on the units that care for a lot of older adults, but across the organization. And then there's also the focus on the interdisciplinary collaboration on those units. How are the needs of older adults addressed in subspecialty rounds? How can nurses discuss concerns about delirium or mobility, or whether or not the patient and family's voice is being heard and advocate for the patient? And so that physical unit, both in terms of the way it's set up and the way we have it for older adults to make it easy for them to have good care, but also how do we work together to collaborate and recognize the unique needs of older adults? Next slide. And these are niche evidence-based resources. The first one is the protocols book that I shared with you. You can see it's now in its 7th edition. The other one is our program, our niche Nurses Improving Care for Health System Elders textbook, talking about niche as a program, how it was developed, how organizations leverage it, how organizations scale and spread it across their organizations and scale this passion and quality work for older adults. And then on the right is our partner, Geriatric Nursing. All niche organizations receive one online subscription to Geriatric Nursing. Niche publishes a column in it. You can kind of see at the bottom, Niche is one of the organizations featured on the cover, and we both publish on our work, but we also encourage the nurses in our organization to publish their work. One of the nurses from NYU Langone Health did a delirium journal project, and she'll be the next column featured in Geriatric Nursing for the niche column. So it's a real opportunity to, early in their career, become engaged in improvement, leadership, and publication. Next slide. And there are two frameworks with niche. Our original framework, these were both developed by Dr. Fulmer. What I failed to say is Dr. Fulmer, after her deanship, was the president, and she is the president emerita now of the John A. Hartford Foundation, only retiring in the last few months. But she developed the initial framework of preventable geriatric syndromes for older adults called SPICES, and we continue to embrace that framework. You can see the case example I gave you, right? The whole idea about problems with eating or feeding was really embedded in the work we do. But she then went on to found with Dr. Don Berwick at IHI, the Age-Friendly Health System Initiative. And from that came the CMS Age-Friendly Measure. Niche had signed on to that along with other geriatric quality organizations, and we're very excited to see its impact. In that framework, there are 4 essential elements: what matters, goals of care, what the patient's voice is, and then also what is the patient's preference on a regular basis, on a daily basis around their care, and also how do we influence them, or to understand that mobility is good for them. Some older adults and their families feel like the patients are in the hospital for rest, when in fact that's the worst thing we could do. We also focus on medications. The 2023, I think there was a 2024 update in the Beers list that we've embraced. And interestingly, the 2024 or recent update, I went to the AGS last year. It's occurring again this year. But they talked about the fact that in the Beers list, there aren't too many alternative medications. And so non-pharmacologic interventions are best. And that's where niche nurses excel. I'll share a little bit more about that later. And then mentation, delirium recognition, prevention, management, team collaboration around that is essential. And then lastly, but not least, is mobility. There's a huge focus within niche organizations on mobility, breaking the conception that mobility is bad for falls and injury, when in fact, as we use it in a balancing measure, our organizations regularly report that falls declined and did not increase when they enhanced mobility. Next slide. And I will turn it over to my colleague Arlene, who is the expert in geriatric quality programs in Massachusetts.
Thank you so much, Karen, and welcome everybody. Thank you for allowing both myself and Karen to speak today. I just want to give the shout out back to Karen. She was actually my mentor and still is. What she's been able to accomplish alongside Dr. Popel with Niche is just truly remarkable, and that's what we want to share with you today. So I'm always pleased to be here and share with you, and just a big shout out to all of our Massachusetts niche hospitals. We are mighty and we are strong. And we're going to talk to you a little bit more about why niche really helps you achieve these goals. Let's start off with some of the geriatric quality programs in Massachusetts. These initiatives all complement each other. They look at different practice areas, whether it be the emergency department, the OR, the nursing practice in the hospital, acute care hospital, or the system, but they all align around the same goal, and that's to deliver safer, more personalized, and age-friendly care that is going to be best for the older adult that is evidence-based. Next slide, please. So this is a list of the Massachusetts niche member organizations. As mentioned just a moment ago, 20% of Massachusetts hospitals participate in niche. I think that Massachusetts, maybe I'm a bit biased, but that we have always been a leader in geriatric care, as you heard with Dr. Terry Fulmer, and we really excel in new initiatives and how do we get involved. So there are three statuses with this, exemplar, senior friendly, and member. And what we're really looking at is, what is in place? Do you have geriatric transitions? Where do you have your geriatric resource nurses and what practice areas? There are currently about 321 last I checked, niche institutions across the United States. And I know that we also have some international, for example, Singapore's on there. Next slide, please. Great. So here comes age-friendly. And the first time I heard about age-friendly was actually at the niche conference. I remember thinking, they said, hey, anyone who wants to learn about this age-friendly, come into this room. And of course, I just went right in there thinking, wow. And it was truly amazing to listen to what their goals were before it ever came to fruition and to get feedback. It wasn't just to tell us what they wanted to do, but it was get our feedback on how we were going to accomplish this. So this is just a list of the age-friendly health systems in Massachusetts. Notice it hits home health and inpatient health systems, nursing homes, and outpatient, and the purple coloring font denotes niche institutions. Next slide, please. And so here's a geriatric emergency department listing of what we have in Massachusetts. You saw that our numbers are high. I am proud to say that we are in the process, and we have been for a while, but I think we're finally getting where we need to be to explore becoming that geriatric emergency department. I talk to our trauma director all the time, and they say that although we're right off of major highway, our top trauma falls from a standing position. So it really is something that I think we all see. And we know that when older adults come into the ED, what happens? They get put into the hallway. They don't have access to go to the restroom easily. So their care oftentimes becomes very fragmented. I know our ED, very few of our rooms have access to even see the window, to see the light coming in from the window to know if it's daytime or nighttime. All right, next slide, please. And here's a look at all the various ACS programs that are aimed at improving care for older adults. The ACS quality programs use standardized and evidence-based practices. The goal is to reduce complications, shorten length of stay, and improve recovery, especially for older adults, as you heard, have these complex needs. Next slide, please. So a little bit about Leahy and our involvement with niche. I actually am going on almost 30 years here at Leahy, but I became involved with our niche program almost from its inception. There was one niche program leader before me for a few months, and then I took over. And I'll never forget that when I first started talking about older adults back in 2010, I could clear a room like no other. People would go running. That's not the case anymore. And I really attribute that to niche. I attribute that to age-friendly health system. We're going to talk a little bit about our Chapter 220. So really the regulations that have helped to strengthen our need to improve care for older adults. So Leahy is a 330-bed teaching institution. We're a level 1 trauma center, and we're a member of BILH. So just a little shout out to my colleagues from BILH. As Karen mentioned, we utilize the GRN model. When I first started in niche, there were a lot of other hospitals that had ACE units, and I always used to think to myself, oh, wouldn't it be great to just have one unit that cares for older adults? And I realized very quickly that all of our units care for older adults. So that's what we follow here. Next slide, please. So they are the foundation. The GRNs are the foundation for our niche program. If we look at our niche program, we start off right away. We start educating about older adults the minute they come into nursing orientation. So on their second day of hire, all members of the nursing department, whether they're licensed or unlicensed, regardless of role, if they're part of the nursing department, they receive education on caring for the older adult. It starts off with communication. We also are able to present to our nurse residents. We have a high number of newly licensed nurses, as I'm sure many of you do as well. And niche has a strong presence within the nurse residency program. And I'm actually one of the first presenters that actually they receive during their residency. So I get them right from the start. And I'll be honest that when I get them right from the start, I get them engaged, and then they want to become a GRN. We do monthly GRN gems where we're having the GRNs themselves write up a short review of an article. It could be something they read in geriatric nursing. It could be something that they saw a webinar or heard about. And what their goal is to just make it so it's short and shareable, that they can share it with their colleagues. Certification, I run a gerontological nurse certification study group. Try saying that fast. I've been doing that since 2018, and I've had over 20 nurses become gerontological nurse certified through ANCC. And when you consider we started with 0, I think that is really amazing. But more amazing than the number is the knowledge they gain, and to Karen's point, how they're able to impact practice and care for our older adults. We train all of our nursing assistants. I know the GPCA is by niche. We call them GNA, Geriatric Nursing Assistant, and we combined it with special skin nursing assistants. We train all of our nursing assistants in proper skin care as well as how to better care for older adults. And that's an 8-hour class. So our hospital is willing to invest that time knowing that they're at the patient's bedside providing this care. And then we do get involved with our community engagement as well. You know, we have at our Burlington Health Fair, we always have a niche table. So we're sharing about advanced directives. We're sharing about sensory challenges that face older adults, and always really just getting them to be aware of what niche is. And we even provide niche handouts about what do you do if you're going to the hospital? What kind of questions should you ask your provider? Next slide, please. I'm a very big visual person. So this is a timeline that says, okay, niche started in 1992 as we identified. We became niche recognized in 2010. And then you started hearing about that age-friendly in 2017. One of the biggest facilitators for our niche program was the law, Chapter 220 law that started in 2018 that looked at how you care for people who have dementia or delirium. And then CMS came out with their age-friendly quality initiatives in 2024. It's important to point out these measures aren't just regulatory requirements, but they're a holistic approach to older adult care that we can significantly enhance patient outcomes and satisfaction. Next slide, please. Just a little bit of the Chapter 220 law. There were actually 10 sections of the law. Many of them pertain to education. Then there was a section that looked at operational plan that's saying that all hospitals, acute care hospitals, had to have an operational plan for recognition and management of patients with dementia and delirium. And it wasn't good enough just to have the plan, but then you have to follow it up with quality improvement were you able to achieve what you said you would achieve? Were you effective in that? Next slide, please. Here's my shout out to Mass Hospital Association. I was so honored and pleased to be working with this work group to develop this roadmap to meet this Chapter 220 law. I just want to point out that it's not linear, that it does go back and forth. It looks at advanced care planning, staff training, history and screening assessment, dementia capable environment, treatment management, and transfer and discharge. So why was this so important for us here? Well, we were able to do things that were able to improve care for older adults. So for example, under history and screening, we'd had a delirium screening assessment at the time we used the CAM. But because of this law, it became required documentation. We increased the visibility. Nursing was doing the screening, but it wasn't going anywhere. So now it's on all summary pages. It became part of our rounding and multidisciplinary rounding. From a dementia-capable environment, we developed a cognitively vulnerable banner to identify patients who had delirium or a history of dementia or a history of dementia. Treatment and management, we were able to develop a BPA, a best practice advisory or our practice advisory for patients who were testing positive for delirium. And then with regard to the transfer and discharge, dementia resources are printed on our after visit summary for patients who have been identified as having dementia. So they came in, they may have had dementia before, but it didn't need any additional resources, but now they did. So those are just a few of the things that came from this law. I'm going to, at this point, turn it back over to Karen.
Thanks, Arlene. In terms of the CMS Age-Friendly Measure, this measure was largely proposed by the Age-Friendly Health System Initiative, as well as our colleagues at the American College of Surgeons and the American College of Emergency Physicians. We are happy to be a supporter. NICH continues to collaborate with all the organizations we've discussed today and regularly are in contact with all of them to make sure our work is aligning well with theirs. The 5 domains are around eliciting patient healthcare goals, what matters, if you think back to the Age-Friendly Health System 4Ms framework, responsible medication management, again, within the framework, responsible or frailty screening and intervention. Now that encompasses really largely both mentation and mobility are embedded there, as well as other cognitive issues such as delirium or dementia and depression. Social vulnerability, which is a significant focus in the American College of Emergency Physicians around elder mistreatment, and we also have an elder mistreatment guideline, but that's another area of focus. And lastly, age-friendly healthcare leadership. So a few comments. Niche nurses are leaders in many healthcare organizations at the tip of the spear at the system level in this. And so we believe and facilitate niche as a community of practice for the nurse leaders within our member organizations. We have 330 member organizations across 4 countries. About 90% of those are acute care. And so out of that, we have a Google group facilitated by our NYU IT team here. And so any niche leader can ask any other niche leader about what they have a question about or what they're doing in terms of practices. So within that group, we saw a huge interest in the CMS Age-Friendly Measure. They were being asked to lead. Interestingly, we just co-hosted a conference with Johns Hopkins Medicine and Dr. Sherry Ling, who's the CMS Assistant Medical or Deputy Medical Director who oversees the Age-Friendly Measure was there. And she said one of the biggest questions they have is around age-friendly leadership. And the great thing is at the community hospital level, our niche organizations had age-friendly leadership within their niche steering committees, not just for the nurses, but also the other disciplines and other leaders that they had invited into those groups. So I have on my agenda to follow up with her in the next week or 2 about this. But we have the opportunity to help organizations facilitate these things. But out of our Google group came an interest in a special interest group. And so a lot of my learning around what organizations are doing is really from the niche community. They've asked each other questions. They have discussed how they're going to report out, and why they're going to report out is whether or not they're meeting or not meeting the domain. And so it's been a really exciting work, and also really brought us together more as a community of nurse leaders. So let's dive into each domain so that you really have a sense of what does it require, what are they asking, and then I'm sure you're already beginning to report on this. Next slide. So the reporting period is already passed, right? So you're already reporting. The attestation deadline is coming up, and it is reported through the CMS HQR system. And this is applicable to inpatient prospective payment system organizations and long-term care hospital payment system. It is not impacting, for example, the critical access hospitals that belong to niche, but they are embracing it nonetheless, but they're not currently reporting on it. Next slide. And so the measures currently are process focused. You avoid penalty by reporting not achieving currently, but Dr. Ling was sharing that that's going to change, and they're looking at what's reportable and working with organizations throughout the U.S. to understand what their experience is with the age-friendly measures. And then there will be pay for reporting coming up. We're not there yet, but it will be coming. So it's great to be embracing it and working to meet those measures, because it's going to pay off for your organization as the measure evolves. It's always better to be ahead of the curve on CMS measures. Having done work in readmission, the hospital readmission risk reduction program, the organizations that got ahead of the curve were much better off in terms of penalty. Next slide. And so let's start with domain 1. This domain focuses on obtaining healthcare goals and treatment preferences that will inform their care decision making and goals. So what are you attesting to? You're attesting that there are established protocols in place to ensure patient goals related to healthcare, health goals, treatment goals, living goals, identification of proxies, identification and advanced care planning are obtained, reviewed, and documented in the medical record. So it's a complex one. And that this is the one, and this reminds me, having been a nurse leader working with Joint Commission, you often see similar language, right? That these goals are updated before major procedures and upon any significant change in clinical status. So along with this, you need a workflow, you need an engaged workforce, and you need that patient caregiver and patient family connection to achieve this. Next slide. And so niche, just pointing you to the protocol book, and there's a number of chapters that we have great evidence-based processes for. There's one on person-centered care. The Valley Hospital did a wonderful publication in niche in their column in geriatric nursing about how they embedded that and how they saw their patient experience scores soar. So twice a day, each nurse asks their patient and documents the response to what matters in their care. They also have a price scaling patient experience question, custom question that asks and helps them about the patient's experience in terms of their goals and helps them measure their effectiveness. And, you know, what's amazing is that documentation field in the EMR then posts to the patient's whiteboard in the room. And the nurses there told a great story about how wowed the patient's family member was when they visited for the day and understood that the nurses, without them being there yet, understood their father's patient-centered goals and were focused on them and even reporting them on the whiteboard in the unit. There's also a chapter on environmental approaches, which I discussed. That's our 4th domain. And what are the right toilet seat heights? How do you use contrast? How do you do cognitive stimulation? How do you have good mobility walking spaces that make patients get out of bed? You know you're on an effective niche unit when you walk onto the unit and patients are up and about, that there's activity going on in terms of cognitive stimulation. There may be a day room in the ACE model. They have a day room. ACE is the acute care for elders model that focuses on the one unit. Arlene discussed that a little bit. That's a great model, and everybody needs to go way past the ACE unit these days. I'm working with a number of organizations who started on the ACE unit, and then thought they had it nailed, and now they turn around and look, and there's older adults in every unit, right? So making sure you have those environmental modifications and also that practice environment that understands values and has care excellence and achieves excellent outcomes for older adults. There's also one on healthcare decision-making and advanced care planning, and then also one on LGBTQ perspectives for older adult care. It aligns with 4M's, what matters, quite well, this domain does. Next slide. And so in terms of advanced care plans and decision-making, niche organizations report practices such as a daily workflow that I just described with what matters, having that reported. Also teach back methods to clarify what the patient and family share and make sure that aligns with the team's understandings. We do also have patient and family education called niche need to knows that each organization can co-brand and use that's at the right readability level. Having been a niche leader in a system, we utilize the one-on mobility, but having that patient and family understand and having good communication, because sometimes the goals of care aren't achievable, but you can start making smaller steps to achieve them. In the beginning, nurses report when they ask what matters, they want to go, go home. That's what matters. Well, let's talk about that as a longer term goal and start breaking that up and helping patients know go home is in our mindset as their goal, but it has to be broken up and begun with getting them out of bed and helping them be mobile for the day. And then lastly, they've also developed frameworks to elicit that patient and family goals with teaching points for clinicians. It is important to educate on clinical workflows to determine, use our gap analyses or other programs work in terms of what you're doing to improve care, but to make sure everybody on the team, regardless of discipline or regardless of whether or not they're clinical, for example, the environmental service team members, safety and security team members, or EVA or nutritional team members understand that. When everyone is aligned on this, it's where things really improve. And so making sure there's good teaching frameworks around what's our workflow, so everybody's aware. I've seen been on a unit when the EVS worker who understood that we were focused on fall prevention and making sure the patients received good care was in the room and noticed the patient was ready to fall, stayed with the patient, notified the nurse, and everybody came in and addressed the issue, and that prevented a fall that day. So we need to think globally about everybody being involved in these challenges. Next slide. Arlene's going to take this over. She's going to tell you about their workflow and what matters most.
Thank you, Karen. And this is just an exemplar, much as Karen was providing you with some other hospitals that we've done here. I want to start off with what matters most. I recently had a nurse manager say to me, it's not about the quantity of time spent in the room with the patient, it's about the quality of that conversation. And I think that's a great selling point for everybody to realize that it's not how much time you spend, it's the time you spent. What was it meaningful? And were you able to identify what mattered most to the patient? So I always say, we want to listen to you. Again, use those buzzwords. So we ask all our patients what matters so we can better care for you. This are really broad questions. So if it helps, tell me more about what's important to you about your healthcare goals today or in the future, or what would make today a really great day? What worries you or concerns you the most about your care, about care of your family? And what we've started doing is putting this on our whiteboard. And my personal story is I had a family member who had quite a bit of functional issues and they were hospitalized. And I sat down and I said, tell me what matters most. And they said, not spending the rest of my life in bed waiting to die. And a little bit while later, I said, okay, let's get up and start, walk around the unit again. And they said, oh, I can't, I'm in too much pain. And I was able to point back to that board and say, well, this is what you said. If you, stay in bed, you're going to decondition more. And what we really do is need to get you moving. So they went ahead and they were able to get moving, but I aligned it with their care with what mattered most. Next slide, please. And this is just what our ideal state is. We're going to get that epic, what matters most. I'll be curious how that will affect because it won't be required documentation. And to Karen's point, leaving it on the whiteboard. But I'm going to turn it back over to Karen. I know we still have a lot to cover in a short amount of time, so I'll turn it back over to Karen.
Thanks, Arlene. We want to make sure it's practical too. Domain 2 is responsible medication management to optimize through monitoring of pharmacologic record for drugs that may be considered inappropriate in older adults due to increased risk of harm. We talked about that. That's the Beers list from Dr. Beers through the American Geriatric Society that we utilize as well. So what are you attesting to? That they're reviewed for, medications are reviewed for the purpose of identifying the potentially inappropriate Beers list PIMS meds for older adults. Based on evidence-based guidelines. The Beers list is an evidence-based guideline from the AGS as well as criteria protocols. There's also a niche protocol. It should be reviewed upon admission before major procedures and again, clinical status change. And once considered, identified, there should be a process around how do you consider discontinuation and or dose adjustments. Next slide. And we do have an excellent chapter on medication management. For years, decades, we've been focusing in on particularly opioids, but also, the atypical antipsychotics used for delirium are really not been established to be evidence supported by evidence. So we really focus on trying to avoid delirium and also have a process where we engage with our pharmacy colleagues. And some places do that on admission. Some organizations have a pharmacy assistant in the ED to do med rec there. Quality medication reconciliation is very important. But there are also pharmacists on the niche steering committee. There may be pharmacists on daily rounds, and that aligns very well with the 4M setting. Next slide. And this is the updated 2023 AGS. And like I said, I went to the AGS meeting last year, and there are very few alternatives. And so the reality is doing other non-pharmacologic interventions, having quality nursing workflows to prevent delirium, to prevent falls, to enhance mobility, to make sure patients are getting adequate nutrition are all key in terms of avoiding inappropriate medication. It's also important, having done this for a system, if you have system level reports that you can utilize to look at what your potentially inappropriate meds are, is very helpful, and then to do a root cause analysis. In our 10 hospital system, we saw one hospital was multiple standard deviations above the norm compared to thousands of hospitals in the Vizient database. And we looked, and it was actually a community prescribing pattern around benzodiazepines, which is a totally different solution than adjusting, your admission order set. And so there needed to be a bigger solution in working with the community. But it's important to understand the Beers list medications, do an assessment of those in your organization, and develop workflows to identify them and remove them. Next slide. So we talked about the workflow. Key players in that workflow are the pharmacists, physicians, advanced practice providers, nurses, and therapists. Touch points are medication reconciliation at quality medication reconciliation at admission, transfer, and discharge. We know many readmissions are due to poor med rec or poor validation of patients' understanding of their discharge medications, where there's unfortunately becomes therapeutic duplications, or they're unclear about what medications to continue. For example, getting more than one statin, or they get a new statin at discharge because their other one wasn't formulary. And in fact, they restart their old statin because it was what they knew from their previous, their primary care doc. So making sure we have stellar med reconciliation processes and patient education, being focused on interdisciplinary rounds, and also acute decompensation. Anytime you have delirium or respiratory depression, there should be a review of their medications. Also, while you're having acute delirium, there should be a focus of what are the alternatives to using medications that are likely not to promote benefit, but in fact to sedate the patient. And so we want to make sure we're giving the patients the best and optimal care in terms of their meds. Next slide. In terms of frailty and screening and intervention, this talks about the physical function, mobility, malnutrition is very important, and cognitive impairment and delirium screening for early detection. Next slide. And this one has multiple attestations. Patients are screened for risks, including mentation, mobility, malnutrition, using validated instruments. I will say that's an opportunity for niche organizations who are smaller and may not have a clinical nurse specialist to work, like Arlene, to work with us here to make sure they understand whether or not they're using validated instruments, ideally upon admission, before major procedures, and upon significant changes in clinical status. The next attestation is that if they screen positive, there are management plans, including but not limited to delirium risks, encouraging early mobility, and implementing nutrition plans where appropriate. These plans should be included in the discharge instructions and communicated to post-discharge facilities. We recently had a nutritionist talk about the fact that a lot of the way traditional orders have been written for diets severely limits the patients to the point where they're not getting any nutrition. And so it's important to understand how the patients can receive good nutrition, even if they have some clinical chronic conditions, because in the hospital, they're less likely to eat, more likely to get become malnourished or acutely dehydrated. And so having a focus on this is important, and having that included in the plan of care. Next slide. Number 3 is on data collection, and this is age-specific data collection. A lot of organizations, as we work with niche, have information about these things: falls, pressure injuries, they call them decubitus ulcers, and 30-day readmissions, but it's not subsegmented by age. This requires subsegmenting by age, and also social factors. So I think that's an important one, especially for the quality team. And then in terms of protocols, that there's a protocol for the emergency department, length of stay and how you're going to manage that. That involves usually more than other team members, but they're focused on having the patients placed within 8 hours of arrival and no longer in the ED, or within 3 hours of the decision to admit. That's where nursing and system-wide leadership becomes very important, because you're going to want to look at your bed management policies, as well as the physical and workflow processes in the ED. Next slide. And then I will let you read this in the slides, but these are many protocols that provide evidence-based practices and interventions for all of these things. Next slide. We've been thinking a lot about frailty here at Niche, and there was a great presentation by one of the niche organizations last week. Frailty probably matters. Age impacts frailty, but age alone does not equal frailty. We know that even in the 85 and older, it is about 1 in 4 older adults that are frail. But there's a myth where people think because you're older, that automatically means you're frail. And it does not. And then one of the other concerns is, because you're older, then patients who are older, are often, their mobility is limited just surely by their age, and it may not even be appropriate. So I list some of the frailty scales, but it is something niche organizations think about a lot. And in terms of aligning, the caregivers, or the right caregivers taking care of the most frail patients. Next slide. These are a few examples of best practices. Again, Hopkins Bayview Medical Center is part of the ACS and SQIP program, and have an excellent process around pre-admission through peri-op to discharge of aligning practices that can that account for and mitigate frailty. Apologies. Also at UCSD and their geriatric ED, they have a best practices around nurses and other physicians and other disciplines collaborating, identifying frailty and mitigating it. And they've had huge improvements in terms of overall readmissions, and also in care costs, with average savings of over $2,000 per patient and 13% decrease in readmissions. Next slide. And then there's new AI predictive models. This is one from Wake Forest and Atrium in North Carolina. I heard another one, like I said last week, that's really aligned well that identifies the frail patients and directs the care to them, and also engages the correct nurses. Like you can see, their geriatric NPs are utilizing that frailty recognition AI to make sure they're seeing the patients who need them most. Next slide. Lastly, or next to last domain is social vulnerability. One of the steering team's questions was around what are you picking for the loneliness question here? So there's a lot of work there. But I will say our colleagues at the Geriatric ED Collaborative have an excellent toolkit on elder mistreatment in addition to our protocol. Next slide. You're attesting to whether or not patients are screened for social vulnerability. I would say the EDs or your pre-admission processes are important here, including social isolation, economic insecurity, limited access to healthcare, caregiver stress. That one's very controversial, and that was a discussion at the Hopkins meeting in terms of how you assess that without putting the caregiver's assessment personally into the record, as well as how do you identify those who have elder abuse. These assessments must be done at admission and again at discharge. Number two, you're assessing to this positive screens result in interventions, and they include appropriate referrals and resources upon discharge. Next slide. These are our protocols that will help guide practice in these areas. Next slide. And then this is our colleagues at the Geriatric ED Collaborative have excellent resources. I included a link in the slides there. Anyone can join, either an individual or a hospital. It's free of charge, so highly recommend utilizing their resources. Next slide. And number 5 is the age-friendly leadership. I commented on this, but the domain seeks to ensure consistent quality of care for older adults through the identification of at least one champion, an age-friendly champion, and/or interprofessional committee tasked with ensuring compliance with all components. Next slide. And that the hospital designates that person, and that these care issues are prioritized is the first thing you're attesting to, and that the individual oversees or the committee oversees these things related to the quality of care, identifies opportunities and updates hospital leadership on needs to providing age-friendly care. That's the first attestation. The next is that the hospital compiles that quality data related to the measure, and these are stratified, again, by demographic or social factors used to drive improvement cycles. This is really PDSA or quality improvement work with maybe a quality improvement plan. Most organizations have. Niche organizations had that at baseline. They have a 2-year plan on how they're improving quality, and have other members, other disciplines on their teams. Next slide. So we're getting to the end. This is just how Arlene and I have seen this, but Arlene, do you want to comment on this one?
Well, we only have 3 minutes. There was a question, so I thought we might address that first. Is there any reference to domain 4, social vulnerability, to cultural sensitive care, particularly for displaced patients that aged in our country? So I didn't have that answer. I thought maybe
it's not specific in there. It's a valid thing to be focusing in on, right? I always think about what's in the line of the regulation, and then what are the contextual factors. Sort of, I always talked about guidelines as what's in the actual intervention, and then what's contextual. I call it between the lines of the guideline. I would see that as something between the lines. As you think about your organization, if you have particularly one, every organization serves different populations. To account for what the population you serve is, and then to have quality improvement efforts around that.
So we just had 2 minutes left, so I just wanted to make sure we were able to answer that question.
Sure, thank you.
I don't know if you want to continue on, or you want me to take the slide. Up to you.
Oh, I'll continue on. So this is, and we're going to do more with following up with Dr. Ling, but this is, the niche steering committee can be certainly embedded within an age-friendly committee, but some organizations it was the start of the age-friendly committee, if there is one. It also should be aligned with the quality committee. At our organization, Niche always presented an annual report to the quality committee and was closely aligned with them. But and Niche steering committees feature and ask quality committee or quality leaders to join within their steering committee to help guide practice, look at data, look at opportunities for improvement. I remember our quality team would bring case risk management cases, and we'd talk about the workflows and the processes of care that could have been better for the older adult. Next slide. And then this is just a great action or a committee agenda, suggested items, thinking about quality data, action plans, quality improvement plans. Who's on the committee, that structural piece around making sure quality is embedded within this, as well as our other members. And then also measuring our program data, how many nurses and CNAs and techs and how many units are we working on? What are they doing in terms of education and certification, as well as alignment with other geriatric quality programs? Next slide. These are our references, and we are right at 1. So thank you so much. Pleasure to be with you.
Thank you. Thank you so much, Dr. Mack and Arlene. I know that I just learned so much about the alignment among niche and age-friendly, and then thinking about our law in Massachusetts here. So I'm sure our audience also really gained a lot. I noticed that a lot of people really stayed on. Those that started stayed with us. So thank you very much for your time and your expertise today. And thanks to everyone in the audience. We have a lot of events that are coming up. You can scan the QR code to see all of our programming. And of note, as long as you're registered for this webinar, you will be receiving the recording to the event as well as the slides. And the program will also be housed on our MHA website under our education section. So thank you again and have a great day.